So, on a quick note, before we begin everything discussed on this podcast, it's for educational purposes only and does not constitute medical advice. Always consult your doctor, pharmacist, or healthcare provider before making any changes to your medications or treatment plans. So we start today. Ozempic, Wegovy, Mounjaro. You've heard the names. You've seen the before and after photos. But do you know what these medications actually do? And what happens when you stop taking them? And today I'm sitting down with a physician training at Harvard who sees weight loss patients every single week. He's going to tell you what works, what does not, and what you absolutely need to know before you start. So stay with us. Welcome to When Food Meets Medicine, the podcast where we explore how what you can eat affects how your medication works and how your health truly thrives. I'm Dr. Remi Olukoya, a pharmacist who believes food and medicine are our partners and not competitors in your health journey. Today we're cutting through the noise on GLP-1s, medications, what they actually do, what you need to eat while you're on them, what the risks are, and critically, what happens when you stop. My guest is Dr. Olayemi Olubowale, Dr. Yemi. He trained at Tulane and completed his internal medicine residency at Duke University. He's now in Boston, completing a fellowship in obesity, medicine, and nutrition at Harvard Medical School, where he sees weight loss patients every week. He's board certified in internal medicine. What I find particularly compelling is his master's degree. It's from Vanderbilt in Medicine, Health, and Society, the foundation that shapes how he thinks about metabolic health, not just as clinical problem, but as a social one. Dr. Yemi, welcome to When Food Meets Medicine.
Hi, Dr. Remi. Thank you for having me and thank you for the introduction. I don't know what more I should add about myself. You summarized everything. That's everything I've
Oh,
done so
good.
far. Yeah, I'm ready for a good conversation.
Good, good. Okay, so this week, we're going to talk about metabolic health as both a clinical and social issue. And as a pharmacist, I see patients come in and they fill their GLP-1 prescriptions every week. I see the confusion. Patients will think that the medication does all the work. Patients will stop eating protein. Patients will regain everything when they stop. So today we're going to address all of that. So let's start with the basic. Let's start from the beginning. What is a GLP receptor agonist? How does it work in your body? And what is the difference between the medications we are hearing about, like Ozempic versus Wegovy, Mounjaro versus Zepbound? And because some patients are confused about these names, who's a good candidate and all?
Okay. Well, to answer the question, we have to start with what is GLP by
Okay.
itself. GLP is a hormone that's naturally made in the body, in your intestine by some cells called L cells. You
Okay.
find those in like the lower part of your small intestine and in your big intestine as well, your large intestine.
Yeah.
But then there's some also in the earlier parts of the small intestine. That hormone that you naturally make goes to GLP-1 receptors in your body. Those are mainly in your pancreas on the cells that make insulin and then on the neurons in your brain.
Okay.
There's also some that they've found in the cardiovascular system, and they're finding GLP-1 receptors kind of spread all over the body. When the GLP-1 molecule, the hormone that you made, hooks up with the receptor, it does a bunch of different things in the body, such as changing like your insulin, how fast your stomach empties. It stops the cells in the pancreas from dying, just a host of different responses to the GLP-1 molecule hooking up with the receptor. So the drug, a GLP-1 receptor agonist, mimics the molecule that you make, and then it binds to the receptor. But the thing is that it lasts a lot longer in your body than the naturally made GLP-1 molecule that you have.
Mm.
So that's why you can do injections once a week and you can see the effect from that molecule that normally circulates for just a few minutes and then breaks down, which allows you to have those changes that people are looking for when they start to use the drug.
Makes sense. So, who is a good candidate? What does the evaluation look like at the MGH Weight Center? What criteria do you use?
So for the patients to end up in the MGH Weight Center, they like to take quote unquote sicker or further along patients. So we use a body mass index, which is a formula where we plug in your weight and your height,
Okay.
and then it spits us out a number. And if that number is above 30, you meet criteria for a clinical diagnosis of obesity. At the MGH
Mm.
Weight Center, they actually want it to be above 32, but the clinical cutoff is above 30 to say that you have a diagnosis of obesity. If your BMI is between 27 to 30, right now you meet clinical criteria for a diagnosis of overweight. These drugs can be used in either populations, reasonably so. Some people with overweight also might have diabetes or hypertension, so you would want to
Yeah.
treat them earlier. Some
Yeah.
people with a BMI greater than or equal to 30 don't have diabetes and hypertension. So it's a very individualized conversation. But the issue is when you have diagnoses of obesity, you're at increased risk for those problems developing at some point in time.
Okay. GLP-1s get all the headlines, but they're not the only weight loss medications out there. What about phentermine or Contrave or Orlistat? Who are those medications right for?
So Eh, I've struggled with this, during my training because objectively, the studies that we have suggest that these GLP-1 drugs lead
Yeah.
to the greatest amount of weight loss. So they're the most efficacious for losing weight.
Mm-hmm.
But any kind of medical advancement throughout history has started being accessible to one wealthier segment of the population initially, and
Yeah.
then became more and more widely available.
Yeah.
So a lot of the consideration for who ends up with these medications that are not as objectively efficacious as these GLP-1 drugs is
Yeah.
like financial coverage and insurance for now.
Yeah. Okay.
Those
Makes sense.
medications are things like phentermine topiramate, the combination drug called Qsymia,
Yeah.
bupropion naltrexone, the combination drug called Contrave, and then Orlistat as well. So those are
Okay.
just different ones that we use. And some people also use metformin off label
Yeah.
to try and get some weight loss as well.
Sure. Yeah, I've seen that. I've seen that in my practice. So I would ask this. Can you share a story? Someone whose life was genuinely changed by a weight loss medication?
Yeah. I think a good example that I have is before I meet a patient, I always look at their medical history and
Yeah.
then I consult the medical literature on the things in their medical history that are influenced by their weight.
Okay.
So some people have migraines, for example, and I have a patient who has a diagnosis of obesity and then she's been suffering debilitating migraines for like the last 10, 15 years. When I met her in clinic, I pointed out to her that people with increased weight have increased frequency and severity of migraines so that
Hmm.
her losing weight might help her with the frequency of her migraines. I wasn't
Migraines. Yeah.
100% sure that that's how it happened, but
Hmm.
that's what the literature said should
Yeah.
probably happen if she starts to lose weight. These headaches were keeping her from being able to work full time, being able to enjoy time with her friends. So we got her started on medication. Her weight began to come down. I basically see people every 6 weeks as we're actively working on the medication part or the weight part in the beginning.
Okay.
And so over the course of each 6 week touch over three of them, I think it was the third visit, she said that she hadn't had a headache in a month, which was the first time that had happened
Wow.
since I think she's 45
Wow.
at this time. That was the first time that had happened
Wow.
since she was 18. So
Wow.
the next time I saw her, she had picked up full time work and was able to, you know, interact with people and interact with her friends in a way that was different from what she'd
Yeah.
done since she was a teenager. And obviously, she didn't really have much insight into how much that was affecting her mental health. But when she
Mm.
got back out there and was able to interact with people more, it did really well for her mental health as well, which was not even something we had discussed too much at that first visit.
What should people be eating while on GLP-1 medications, and what should they be avoiding?
Okay. So the GLP-1 medications, the start of my thought process on that is they slow down the process of how fast your stomach releases food into your intestines. So it kind of
Okay.
holds food in the stomach. When that is happening, the things that might make you a little bit more uncomfortable are like fatty or greasy foods, because
Yeah.
ideally you want those to move through so they can be broken down by lipases and different things from the pancreas, which is attached to the intestine. So when people eat greasy foods and it sits in the stomach, they feel not so
Yeah.
great,
Yeah.
which is actually like one of the beneficial technically aspects of the food because it'll decrease the frequency with which you want to consume
Mm.
fried foods and greasy foods. So that's a plus. Things that we want you to eat, because when you're losing weight, you're not just losing fat. The simple way we say it is, if somebody loses 3 pounds, 2 pounds of that will be fat, and then a pound of that will be lean mass. So that
Mm.
could be muscle, bone, maybe like organ density as well,
Yeah.
connective tissue. And so we want to hold on to that pound, right? So
Yeah.
we need protein to be able to make sure that our muscles are getting enough fuel or substrate to be able to maintain themselves.
Yeah.
And then the third thing that you'd want to consider is you really want to eat high fiber foods, because
Okay.
when your stomach emptying is slower like that, once the fiber hits your tract, it is able to move a little bit more continuously through. and
Mm.
pull all of the food together to allow you to have good solid stools, because constipation is something you'd be worried about. You slow down how fast your GI tract is moving food through it.
Interesting. I know that the protein piece is quite critical. And I know that when you lose weight rapidly, you lose both fat and muscle. Like you said, if you're not eating enough protein, you lose more muscle than fat. And I know that muscle is your metabolic engine. From my side, the general recommendation normally is, like you mentioned, the grams per protein. And what do you tell patients who struggle to eat those protein targets?
I
Uh,
In the real world, I just tell them to do the best that they can. Some of the
yeah.
protein recommendations, like functionally, are a lot of this. There's no clean answer for what
Mm.
like we really should be eating.
Yeah.
Basically, you can say target 60 grams of protein a day, but
Okay.
I've seen optimal recommendations of 1.2 grams to
Yeah.
1.6 grams per kilogram
Yeah.
of protein.
Yeah,
That's
that's what I've
a
seen
lot,
too.
a
It's
lot,
a
a
it's
lot
a
of
lot.
protein.
Yeah.
So I just I
Yeah.
just tell them to target 60 grams, but then tell them what the ideal is, and then set 60 grams as a floor, and then we try and get more if we can.
Okay. Actually, that makes sense. Now we go to the food drug interaction piece of it. The art of our show. The high fat meals can worsen GLP-1 side effects significantly. Alcohol slows the speed at which food leaves your stomach even further, and I know it causes unpredictable blood sugar spikes or swings. And I actually built a GLP specific meal plan as part of my PharmaPlan resources, protein targets, trigger foods, nausea management, all one piece. But what nutritional deficiencies should patients on GLP-1s watch for?
The main thing is that this drug, since it works on the GLP-1 receptor in your brain and it leads
Yeah,
to appetite suppression, I
yeah,
don't really see, or I've not seen personally in my clinic, any like micronutrient deficiencies, things like
mm,
vitamin A, the different B vitamins, vitamin C.
yeah,
I've seen more about like total caloric deficit being the problem. And we definitely want to
mm,
hit a minimum of 1,200 calories a day.
mm,
So it's not specific micronutrients that I've seen play out so far that people should be worried about with GLP-1s. That's more of a
yeah,
problem with bariatric surgery and then
yeah.
the way that different things are absorbed. The
Okay,
GLP-1 drugs seem to be more about you need to make sure you're eating enough calories.
okay. So what common side effects do the patients you see normally have from the
The way that I counsel
GLP-1s?
them and the easy way to remember it is that your gastrointestinal tract from your mouth to your backside or to your butt is, if you can imagine, it's basically a straw. It's just one big straw. In between
Uh-huh,
that, you have like your stomach and your intestines. This
uh-huh,
medication slows down how quickly things would move through the straw. The top opening is
mm,
your mouth, the bottom opening is the backside. So if things are sitting in one place within the straw
yeah,
and you try and stack food on top, you're going to feel nauseous. You
makes
might
sense.
vomit the food back up that you're trying to
Mm,
stack on top. This is
makes
just
sense.
sitting there. And then
Yeah.
if you're trying to get things out through the backside, but it's moving slowly, you're going to deal with constipation.
Mm,
Some people, because the GLP-1 molecule is secreted by the L cells in the like large intestine, it changes that secretion and they might have diarrhea. So then what I
mm,
tell them is you look for any changes in your poop. So some people have diarrhea, but the thing that makes the most sense is constipation. So
okay.
I just tell them, let me know if you have any changes with how you're pooping, and then
Yeah.
any nausea and any vomiting. Those would be the main things we think about. And then because there's the receptor on the beta cells in the pancreas, we look for inflammation of the pancreas as well, something called
Mm,
pancreatitis.
okay. Oh, so how would they know they have pancreatitis? If what are the symptoms they should report when they feel that they're having such information?
Pancreatitis is just a very, 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 very severe abdominal pain. It would
Mm,
be something that you've not experienced before in the
mm,
upper middle part of your belly. There's
okay.
not really much more to know than that. If somebody tells you, if you have any strange new abdominal pain, let us know. That
Okay.
is more than enough for you to be able to catch the idea of
That
pancreatitis.
okay, makes sense. So I'm going to ask about contraindications now. Who should not be on, GLP-1s?
People that are pregnant or trying to get pregnant should not be using weight loss medications in any way, shape, or form.
Yeah.
That's one. The second group with the GLP-1s that you want to be careful about are people with a history of disordered eating or people that are like, interested in it for
Okay.
looking for a way to lose further weight, especially if they don't meet the criteria, like a BMI greater than or equal to 27 and forward. you really don't need to be giving that to people. A lot of these, like telepharmacies are just giving the medication to whoever, but
Yeah,
that's not
I
the
agree.
population it's intended for. And
I agree.
it's a
Totally agree.
it's a version of that medication actually. So
Mm.
those would be the two big populations that you want to think about. Yeah. The third population you want to think about is anyone that already has a history of slow stomach emptying, something medically called gastroparesis.
Okay.
Um, I have used it in people with gastroparesis at lower doses, but it's just something you want to be careful about. It's not an absolute contraindication. We call those relative contraindications.
So I think I would want to talk about life after GLP-1s. I know GLP medications are powerful tools and they're not for everyone, just like you said. We've discussed common side effects that people, how do you think they should manage it? If you have a story you can share about patients managing the common side effects and what are the serious risks? I'm sorry, we did mention that. How do people manage those side effects?
Well, with respect to the nausea and the vomiting, people just eat smaller, more frequent meals throughout the day.
Okay.
Part of why I think this field is interesting is because it's so centered on human behavior.
Yeah.
And the idea of breakfast, lunch, and dinner is not something that is biologically set. It's something
Yeah.
that's more socially set, that we
Yeah.
carve out time in the morning to eat, time in the afternoon to eat, time in the evening to eat.
Yeah.
But these people, they feel more comfortable if they eat a little bit in the morning, a little bit in between breakfast and lunchtime, a little bit at
Yeah.
lunchtime, a little bit between lunch and dinner, and then a little bit at dinner.
Yeah.
Knowing the times at which they're eating can help with that. There's medications that you can use for nausea as well, but we need to make sure that those medications can affect the conduction in the heart or the class of
Mm.
one we use. So we make sure that they have a safe profile if we're giving that to them.
Yeah. Makes sense.
And then just modifying the food that you're eating, period, avoiding like the fatty foods
Fatty foods. Yeah.
would be the ways that people handle nausea and vomiting. And then from a diarrhea perspective, there's medications that if you have diarrhea, there's medications we can use for the diarrhea.
Yeah.
And then constipation, targeting and making sure that you're eating high fiber foods, drinking enough water,
Yeah.
and there's medication for that as well.
So now the question everyone is afraid to ask, what happens when you stop? The data is clear. Most people regain a significant portion of weight when they discontinue GLP medications. Why does that happen? And what can patients do about it?
Yeah, there's two good trials that look at this. Surmount 4 trial, where they use tirzepatide and they look and see what happens when they stop. And then the
Mm-hmm.
STEP 4 trial, when they
Mm-hmm.
look at semaglutide, which is Ozempic and Wegovy, and see what happens when they stop. The
Yeah.
majority of the people regain the weight.
Mm.
Um, Anecdotally, this is not proven in any kind of study that I've seen so far.
Yeah.
It's hard to prove what I'm going to say here, but the people that seem to do better if they desire to stop are the ones that made comprehensive lifestyle change while they were using the medication
Yeah.
and they got the boost to lose the weight. And when they arrive on the other side, their life, it looks completely different from a sleep perspective, from a diet perspective, from an activity perspective. But a lot of people, like, given the limitations of modern life, not to blame anybody or anything, that's not the point,
Yeah.
aren't able to make such comprehensive lifestyle changes and they slot back into their old life and then the weight comes back.
Yeah. I totally agree with you. Lifestyle modification is quite important. I I've seen people on GLP-1s that, like you said, when they change what they eat, when they exercise and do things right, by the time they get on, it becomes a lifestyle. They're used to doing that exercise and eating well, and the weight stays off. So now we're going to go to a segment called Rapid Questions. I would ask you a question and then you answer. So, the first one food every GLP patient should be eating more of.
I don't know about should, but what happens is everybody loves Greek yogurt because you get in a
Okay.
lot of protein.
Okay.
At the close of this call, you can go read about how much money Chobani has been making since people
Mm.
started to use these drugs.
Mm.
It's an easy way to get in some protein at breakfast time for a snack. I don't know about should. They don't pay me, so I can't say you should eat Greek yogurt, but it's an easy way for people to do. So
No,
say
good.
Greek yogurt probably.
Good. That's good. Okay. GLP medications, game changer or overhype?
I actually think that I cannot overstate how much GLP-1 medications will change Western society. 70% of people right now in America meet criteria for a diagnosis of overweight and obesity. So not to say that everybody's going to end up on it, but if a significant amount of people end up on it, you're changing how they eat. That will impact fast food chains, which, take up a
Yeah.
lot of the land space in the United States of America.
Yeah.
Who's to say that those buildings, if these companies, are to
Mm,
contract or go under, that's a lot of space that will be for
yeah.
sale. There's so many, you could not even possibly overhype what this medication is probably
I'm gonna do.
going to
Mhm.
change in our society. So
Yeah.
game changer.
Yeah. Game changer. Correct. I think so too. What are the options for patients who want to stop
Mhm.
or cannot afford to stay on medication?
You could just stop. That's one.
Is
Of
there
course, we know that
tapering?
the
Yeah.
likelihood is you're going to regain. Yeah. No. You don't necessarily have to taper because the issue is the access. So it's not like you're going to go through some kind of withdrawal or have a problem if you don't taper.
Yeah.
But the appetite suppression piece can come roaring back if you just went from a high dose to nothing.
Yeah.
So that's the main concern. But there's nothing physically that's going to happen to you necessarily. The studies say that you're more likely to regain the weight. So you could
Mm-hmm.
try a different medication at the transfer point,
Mm-hmm.
but it's up to patient preference. In the weight management clinic,
Yeah.
the main thing is that the patient has to drive their plan because there's nothing that I can do. Once they leave, they do most
That
of the work. It's not like you know, it's not like treating your cancer where I
they
give you
have
the chemo
they
and it's
have to
doing
do the
everything.
work.
You have to do it.
Yeah, they
Yeah.
have to do the work. So
Yeah.
can this they can cycle on and off? Is that safe to like go off and then go back on?
And the
So,
cycling piece is not so great because you're more likely to have side effects when you reintroduce that medication, right? Even the
yeah.
way we start the medication is at a very low dose, and then
Yeah.
we gradually work our way up. So when you're cycling on and off, you're increasing the risk for that terrible nausea, that terrible vomiting, changes in your
Yeah.
bowels because
Yeah.
it's like a spike and then it goes down and you're spiking. So
Makes
we don't
sense.
really do the cycling as much, but that's the thing. We don't have clear answers for a lot of these things
For now. Yeah, for now. So let me ask directly because I know
for
that
now.
our listeners are thinking it. For patients who make an intentional decision to come off GLPs, it could be cost, it could be they reach their goal and they think they're done, or they want to manage on their own. What does a responsible transition look like? What should they be doing in the weeks and months after stopping in terms of nutrition, movement, mindset, and to give themselves the best possible chance of holding on to their progress.
Well, I think if we're saying they're going to completely stop, I think that when I meet somebody, we talk about their lifestyle, and I break it up into 4 different categories for your lifestyle: diet, physical activity, sleep, and stress. So at the
Mm,
beginning, when we do that history, they might tell me, okay, this is the problem with diet. This is my problem with activity. This is my problem with sleep. This is my problem with stress. A responsible way to come off would be to look back at those categories from the beginning and see what
mhm,
has changed in each of
mm,
them and
mhm,
the likelihood of us being able to maintain those changes,
yeah,
right? So the one that would be most likely to go backwards if you stopped it would be the diet. But let's say that their diet wasn't as big of a problem at the beginning, then maybe that's less of an issue. And the issue
mm,
is more about how they had terrible sleep and they weren't exercising, but those are completely different now. So if they are insistent that they should stop, we should look back at the lifestyle and say, what has changed and how likely are we to maintain these changes?
makes absolute sense. So what is your vision for the future of obesity medicine? Where is this field going in the next 5 to 10 years?
Uh, That is an ongoing debate at where I work. I have a unique or different way of thinking about the field.
Okay, I would
Primary
like to
care in
know.
the United States of America has all of its known challenges.
Mm-hmm.
Primary care in America has all of its known challenges. Not that many of the junior students are going into primary care, issues with
Mm,
long work times, responding to patients. And part of that problem, apart from system level issues, is that the patients are like much more sick than they were
mm,
decades before. But those patients that are much more sick oftentimes have the diagnosis of obesity, right? They're more likely to
mm-hmm.
have, that's more likely someone to walk in with heart failure and diabetes and hypertension and B and C and D and E, right? So I think that obesity medicine could serve to remove those patients from the primary care workflow,
Yeah,
able to focus on them in a primary care-ish kind of way,
yeah,
to allow the system to be better utilized by people that just have, one thing or two things they need to stop in and check with their PCP on. Because those PCP appointments are 10 to 15 minutes. You
yeah, in and
realistically
out.
can't care for some of these people in 10 to 15
Correct,
minutes and give them,
correct,
it's okay.
correct. Yeah.
Yeah, you're in and out. So that's one piece. The second piece from obesity medicine is uh, all of our studies, you know, to understand obesity, you have to understand what's going on from a society level.
Yeah.
The push to change some of these things from a health-centered angle could be very useful,
Yeah.
making our cities more walkable, access to technology and screens for children and like policy around those things.
Yeah.
Obviously, you will know where I stand. I would just want people to be healthier, and I want the policy to allow people to be healthier.
Yeah. Yeah.
Whether that falls on whatever side of the politics that you think is immaterial to me, it doesn't really matter.
Yeah.
The main thing is like the health. So coming at it from a health angle to try and influence policy could be a way to move things forward, but that requires everybody caring about our
Everybody's
health.
hands on the deck. Yes. Yes, I do agree. So, next question. One food that makes GLP side effects worse. If you could think of one.
Good.
Yeah.
I always tell my patients, I'm not going to tell you that you should not eat at, I won't name any fast food chains. I'm not trying to get, I don't want to get sued or anything. But fast food in general,
Yeah.
by the time we start to work together, you will look at fast food and be like, oh, I'm not interested in that. So I will not call out any fast food chains, but just that prepared food sitting there, very high in fat and sodium. People just end up not wanting it or not liking it after we work
Mm.
together for a while.
Well, that's good. Without naming names, Ozempic or Mounjaro, if you had to choose for
Mhm.
patients.
The Mounjaro has better proven weight loss in the clinical trials. Both of those drugs are for diabetes. So the split in their weight loss profiles is less so than the split between Wegovy and Zepbound, which are
I said
for weight
bound.
management
Mhm.
in people without diabetes. Mounjaro is more of an efficacious drug, and people tolerate it better.
Okay, good. Can you maintain weight loss after stopping GLPs without medications?
It is very possible. Very possible. Can I say likely or statistically what happens most of the time?
Yeah,
No,
please.
but it is very possible.
Yeah, good to know though.
Yeah.
What is the biggest mistake patients make on GLP medications?
Not thinking that they need to exercise. They think
Mm,
that the medication does this for me.
it's
I
magic.
I try to stress it to everybody that like I am telling them that if I cannot get you to exercise, I am really, 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 really failing at my job. You should
Mm,
be lifting weights to try and hold on some muscle to
muscle.
protect your bones as well. Because when you're losing weight like this, you're losing bits of muscle and bone. But
Mm,
if you do some resistance training and eat the protein, you can hang on to that muscle. It's so much harder to add on muscle at 50 years old.
mm.
60 years old. You can add on muscle, if you're 20 or 30. But for me
It
to
becomes
take away your
harder.
muscle that late in your life, it's not a good thing. And we need to make sure that we do everything we can to hold on to it. So
Yeah, I totally agree. Totally agree. Coffee or tea? What's your take? You take coffee or do you take tea?
my mom was born in England, so I used to drink tea, but I don't drink tea too much. But I drink coffee. I always say this. I only drink coffee on the weekends. I don't drink coffee for work. I just drink
Um,
coffee to enjoy my day and feel like I have energy if I have a day to enjoy or if I travel or something. So I would say coffee because it makes me think of trying to enjoy my day.
okay. One piece of advice you'll give your Vanderbilt graduate school self.
Well, I guess I would tell him, don't be frustrated. The way that they taught me there is like very, very, very different than the schooling that a lot of my colleagues have. So I
Mm,
just see problems from a different angle because I did that. Like I've noticed that like when you just talk to people and you point it out to them, they're like, oh, wow, I just never put two and two together. So just because I
mm,
sat there and had time and was taught on how to put
mm.
the two and two together doesn't mean that like, other people are bad. It's just that it's literally my job. That's why I learned it was to go and try
Yeah,
and share it with people.
yeah, yeah, yeah. So finish this sentence. GLP medications are a tool, not a kill. The real work is.
Understanding how your life works and trying to just make it as good as you can make it within the boundaries that you have. The GLP-1s are like a support to kind of get you started on that journey and help you with the weight loss. But the real work is changing our life.
Okay. So before we go, there's one message you want patients who are considering or currently under weight loss medications to take away from this conversation. What is it?
Lift weights, lift weights.
It's weights.
Women,
Okay.
men, everybody
Should
lift
lift weights.
weights.
So we start from little till we get to a
Mhm,
very comfortable weight level. Okay. I think I need to take that advice. So,
mhm.
Dr. Yemi, thank you so much. Tulane, Duke, Harvard, and you're still in training mode and still asking questions, still building expertise. I thank you for your intellectual humility. And the patients at MGH with Center are very lucky to have you. And our listeners are lucky to have you
Thank you.
today. So, three takeaways for everyone. One, GLP medications are powerful tools, not magic. They work best when combined with the right nutrition, adequate protein, regular movement, and proper medical monitoring. Do not use these medications without a healthcare provider. Number two, protein, fiber, the important nutrients on GLPs. Aim for better and protect your muscles. Your muscle is your metabolism. Number three, if you want a done for you meal plan specifically designed for patients on GLP medications with protein targets or triggers, food guidance, nausea management strategies built in. This is exactly what I built in my PharmaPlan resources. So the link is going to be in your show notes. Dr. Yemi, where can people find you?
Yes. My clinic is the Massachusetts General Weight Center. It's in Boston, Massachusetts.
Okay, no problem. We'll put it in the show notes, and wherever you want people to reach out to you to, that's okay. So if you feel that today's episodes helped you, share with somebody who's asking about weight loss medication. It could actually genuinely change how they approach their health journey. So please subscribe to When Food Meets Medicine so you never miss an episode. So until next time, eat smart, your meds matter, and your body will love you for it. Thank you, everyone.